Welcome back to The Explainer. I'm Harshal, and today we're acting as your expert guides to the complex world of medical coding. We're going to decode a super specific but absolutely crucial topic, mastering the CPT 2026 Home or Resident Services Guidelines. If you're coding for providers who, actually step out of the traditional office setting, you absolutely need to know these rules inside and out. So let's just get right to it. Okay, here's our quick roadmap for today. We'll start with the scope of home services, break down the specific codes for new and established patients, tackle the dreaded travel time exclusion, and finally, wrap up with billing prolonged services. Section 1. Scope of home services. What actually qualifies as a home in the CPT 2026 guidelines? We got to establish our setting first, right? Because home or residence covers way more than just your typical suburban house. The CPT definition is incredibly broad and honestly really accommodating to where patients actually get care nowadays. Yes, obviously it includes private homes, but it also covers temporary lodgings. We're talking hotels, hostels, and even, get this, cruise ships. It also extends to assisted living facilities, group homes, custodial care facilities, and residential substance abuse treatment facilities. All of these are billed using the exact same code set. And looking right here at the actual wording from the CPT 2026 codebook, you can see how they've taken what used to be separate domiciliary or rest home codes and just streamlined them into one single category. It's kind of nice to see it right there in black and white. Whether your doc is in someone's living room or checking on a patient at a substance abuse facility, you're looking at the exact same family of codes. Moving right along to Section 2, New Patient CPT Codes. Let's break down 99341 through 99345.
So when you're evaluating a new patient in these settings, we've got 4 codes to choose from, based on either medical decision-making, MDM, or total time. For 99341, you need straightforward MDM or 15 minutes. For 99342, low MDM or 30 minutes. Now check this out. Look closely. There is no 99343. They skip straight to 99344, where moderate MDM needs 60 minutes. And finally, hitting that high MDM for 99345 requires a 75-minute threshold.
You can see these exact thresholds documented right here in the primary source text. If you're selecting your level based on time, these are the precise minutes you have to hit or exceed on the date of the encounter. Literally lock these time frames into your brain. It's absolutely crucial for keeping your billing perfectly aligned with the guidelines. All right, Section 3, Established Patient CPT Codes. Let's break down 99347 through 99350. What happens when the patient is already established? Well, the times shift quite a bit. Straightforward MDM starts at 20 minutes with 99347. Low MDM with 99348 requires 30 minutes. Moderate MDM with 99349 bumps up to 40 minutes. And then the high MDM code, 99350, maxes out at a 60-minute threshold. The big takeaway here, the highest level for an established patient requires a full 15 fewer minutes than the highest level for a new patient. Which brings us to Section 4, the travel time exclusion. This is a critical coding rule, guys. Okay, before you go assigning those time-based codes we literally just talked about, I need to point out a massive gotcha that trips up so many coders. Here is the golden rule, right in the guidelines. Provider travel time can never be counted toward total time calculations, no exceptions. If the doctor spends 45 minutes stuck in brutal traffic driving to the patient's house, 0 minutes of that drive can be used for the EM code. For billing purposes, that car ride basically didn't happen. So what can we actually count? The good stuff. Preparing to see the patient, reviewing tests, doing the actual exam, counseling the family, typing up the notes in the EHR, care coordination, all of that counts. But what's strictly off limits? Travel time, obviously. But also time spent on any separately billed procedures or just general teaching that isn't directly related to managing that specific patient. You got to isolate just that pure E&M service time.
Finally, Section 5, Billing Prolonged Services. Let's look at how to use code 99417.
Let's talk about those crazy edge cases where the encounter just stretches way beyond our highest level codes. To use the add-on code 99417, you have to meet some really strict criteria. First off, it has to be tied to the absolute highest level base code. So for home services, that's going to be 99345 for a new patient or 99350 for established. Second, the total time has to exceed that base code's threshold by at least 15 minutes. Third, it has to happen on the exact same day. And lastly, only physicians or qualified healthcare professionals can use it. This snippet perfectly captures the essence of 99417. It's strictly for, quote, each 15 minutes of total time beyond the required time of your primary service. Since it's an add-on code, you're always going to list it separately on your claim, right below that primary E&M code.
And just to hammer this point home, because it's so important, the guidelines are super explicit that you cannot use 99417 for anything less than that full 15-minute chunk. If your doc goes, say, 14 minutes over that max threshold, too bad. You cannot bill 99417. You literally have to cross that full 15-minute finish line to append the code.
So what does this all mean for you? Well, I hope this explainer has given you the absolute confidence to navigate the 99341 to 99350 code set like a pro. You've got the definitions down, you know the exact time thresholds, you know to completely ignore travel time, and you know exactly how to capture those prolonged services. With mobile care on the rise, mastering these non-traditional codes is a total game changer for your practice. Are your billing systems ready to adapt? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.